So let me start with a piece of old information. This is a study that we published from my hospital in 1994. We were looking at renal dysfunction, risk factors for this, and we could find this interesting relationship. The more you hemodilute the patient during perfusion, the more you will have a risk of postoperative renal dysfunction. 20 years later, this appeared in 2014 in another study, we could confirm basically the same relationship. So it is still true that hemodilution, severe hemodilution is bad, but if you look at both the relationship, there's some interesting point. That 20 years later, for the same level of, let's say, risk, the same level of hematocrit, the risk of renal dysfunction has severely decreased. So why this? Of course, 20 years later, we have many more improvements in CPB techniques. And let me simply quote a number of these. I will briefly address everything. And let's start with biocompatibility. When I started this work, biocompatibility was nothing. We had no treatment. We had platelet adhesion, complement activation, inflammatory reaction, coagulation activation. Then in the mid-90s, we started using the first biocompatible treatments, and nowadays we have a number of possible treatments. Practically every oxygenator is now treated with different kinds of biocompatible treatments. And does this work? We did this meta-analysis some years ago, and it seems that, yes, basically there is a certain trend towards a lower rate of transfusion, towards a lower rate of atrial fibrillation, and maybe a shorter ICU stay. But what we concluded was that if you simply use biocompatible treatments and you don't do anything more, then there is a limited clinical benefit. And this introduces a second problem that we should probably address in the context of the pump and the circuit, the biocompatibility. So this introduced the concept of the minimally invasive CPBs that we know very well now, and this includes a number of methods, not just biocompatible circuit, but closed separation of shed blood, low priming volume, maybe in some cases even reduction of heparin, and nowadays we have again a number of different circuits produced by different manufacturers. And this actually seems to work. Again, this is a meta-analysis that we did with different kind of mini CPB circuits, and we could clearly demonstrate that there is less transfusion whenever you minimize the circuit. And even the guidelines, what they are telling us, we need to minimize hemodilution. We suggest to use minimized CPB circuits. So in the minimization of the circuit, the oxygenator plays an important role, because we know that hemodilution, again, per se, is bad. Hemodilution is bad for the brain. See here how the stroke rate changes the more we hemodilute the patient. And this is confirmed by this other study. And actually, we can even identify a cutoff value for brain dysfunction for stroke. That is around 21% of hematocrit. And for the kidney, it's even higher. It seems to be around 24% from our studies, and even from the huge study from Robert Habib, again, it's around 25%. So if we want to minimize the prime, we need low prime oxygenators and other kind of measures. So again, we have nowadays very low priming oxygenators that we were lacking 20 years ago. And we actually tested one of these in this recent study. We could demonstrate in a huge amount of patients that using this low priming volume oxygenator was actually associated with a lower rate of transfusion, but most importantly, in a multivariable analysis, even a reduction in the acute kidney injury rate. And this is the graphic analysis of what we could achieve using a low priming volume oxygenator. Then another very important improvement is related to monitoring. Well, in the 90s, what the perfusionist had on board was simply a pump flow, pressure, and then urine output and intermittent measurement of some variables. Nowadays, we have a huge amount of brain function monitoring available, like NIRS, like transcranial Doppler. We can address coagulation in much better ways than simply using the ACT. But most importantly, what we now have is the possibility to look at the number of metabolic parameters during CPB. And this is a system that is actually measuring online the DO2, the SVO2, the VO2, a number of very important metabolic data. But data is nothing without interpretation. And the interpretation is that what we could clearly demonstrate, and is nowadays very well accepted, is that if you perfuse a patient under a certain critical oxygen delivery, then all your risk increase, and specifically, again, renal dysfunction can increase if you perfuse the patient under this cutoff value that is around 270 milliliters per minute per square meters. Because below this level, then you enter the anaerobic zone. Then you start producing lactate. This is a critical DO2. And in this study, it was clearly demonstrated that those who were treated below this level of DO2, they were experiencing an acute kidney injury with an odds ratio of more than 2, so more than double. So what's going on at this level of hematocrit? Why this is so much linked to the oxygen delivery, this 24? If you simply do the calculation, then you discover that at an hemoglobin level of 8, that is about 24 hematocrit value, with a pump flow of 2.4, that is a classical value, then this corresponds exactly to this critical oxygen delivery. That's why measuring oxygen delivery is nowadays very much important. And this is a so-called goal-directed perfusion concept. The goal of the perfusion is let's keep the patient into the safe area, and the safe area means a normal or almost normal oxygen delivery. So to do this, the perfusionist should change the paradigm. No more pump flow adjusted simply on the basis of body surface area and temperature, but a pump flow that should be individualized and basically related to the level of hemoglobin. So this is the concept. The concept is compensating low levels of hemoglobin by increasing the pump flow. And I would say, to me, the main reason why we could achieve this decrease in acute kidney injury at the same level of hematocrit was that we nowadays, and during the last, let's say, 5 to 6 years, we were routinely using this concept. Higher flow, higher DO2 whenever the hemoglobin was very low. So in practical terms, we must nowadays measure a number of metabolic parameters, and this perfusion pattern is adequate, and we can check this with this kind of goal-directed perfusion monitor. The DO2 is 270, and all the other parameters are within the normal range. But then you can see that maybe something starts happening. Maybe the SVO2 starts decreasing, and this is the first signal, as in this case, that probably perfusion pattern nowadays is inadequate. And then if the DO2 falls below the critical level of 270, like in this case, then this perfusion pattern is certainly inadequate. So you have to react. The perfusionist has to react by increasing pump flow, increasing hemoglobin using hemofiltration, preventing hemoglobin changes, just to avoid this, that is a classical, very, very bad pattern of inadequate oxygen delivery. So in conclusion, this is what we have experienced as an improvement in the perfusion techniques, and this is what we are doing in our daily practice. But of course, having all this data is important. Interpretation of the data is important, but of course, interpretation is nothing without the knowledge of what's going on. Knowledge of physiology is the basic information that we need. Thank you very much.